Hi, my name is Dave Hutchings. I'm a cardiology registrar and a BHF clinical research fellow here at the University of Manchester, and I'm presenting our paper which looked at the effect of phosphodiesterase 5 inhibitors on overall mortality in a patient cohort at high cardiovascular risk. PDE5 inhibitors such as sildenafil, tadalafil and vardenafil are drugs that are widely used in the treatment of erectile dysfunction and as such have a proven safety profile. They act by preventing the breakdown of an intracellular messenger, cyclic GMP, in various organs including the peripheral vasculature and the heart. It's been shown in animal models that these medications have cardioprotective actions where they can reduce myocardial infarct size following an MI, they can improve contractile dysfunction, and in several small studies have suppressed ventricular arrhythmias. So far there's been very little data on the effects these drugs have on long-term survival in patients at high cardiovascular risk, and we therefore theorize that PDE5 inhibitor use would be associated with a reduction in all-cause mortality, and secondly that this effect would be larger in patients who have had a prior myocardial infarction. So data was taken from the electronic health records of a cohort consisting of just under 6,000 men with type 2 diabetes in Cheshire, United Kingdom. We established exposure to PDE5 inhibitors as receiving a prescription prior to the date of cohort entry and at least once up to the end of the study period. Data was collected on potential confounding factors. Dates of death and new incident MI were again ascertained from GP records, and data was collected on whether they had received a prescription or not. We used a multivariable survival model to estimate hazard ratios for mortality for those who were and were not prescribed a PDE5 inhibitor. We adjusted for age, smoking status, EGFR and past medical history, including stroke, myocardial infarction, hypertension and medication use. After a mean follow-up of 7.5 years, the Kaplan-Meier curve here shows the relative survival in PDE5 inhibitor users versus non-users. All-cause mortality rates were 30% lower in the PDE5 inhibitor group, and this effect remained in a propensity score matched cohort. The association between PDE5 inhibitor use and mortality after adjusting for multiple risk factors is shown in the forest plot. Similarly, in a subgroup of patients with previous myocardial infarction, risk of mortality in the PDE5 inhibitor group was approximately 40% lower. And finally, there was also a reduction in the incidence of new MI in patients taking a PDE5 inhibitor. So, in summary, our findings demonstrate an association between PDE5 inhibitor use and reduced mortality. Furthermore, a larger reduction in mortality was observed in patients with prior myocardial infarction, and given that an estimated 70% of deaths in type 2 diabetes are attributable to cardiovascular disease, we feel this highlights potential cardioprotective actions of the drug. There are several limitations to consider with our study. We firstly cannot infer causation from observational studies of this type, and differences between the groups could be explained by confounding factors which we were unable to measure and account for. Secondly, because PDE5 inhibitors were taken PRN and not continuously, we weren't able to accurately define the extent of exposure to these drugs. In summary, PDE5 inhibitor use is associated with large reductions in mortality in this cohort at high cardiovascular risk, highlighting potential cardioprotective effects. Finally and importantly, we'd like to acknowledge the support of the British Heart Foundation and the NIHR in helping to fund this research.